I'm Dr. Bansal, chairperson for this session. And the first presenter is how to engage B-hex pupil expander and pupil margin in a small pupil phacoemulsification. Chief presenter and author Shalini Kumari. So by the time she gets ready, it was my idea, but there are many small points which cannot be covered into the instruction courses, which is very long, and most of the time presentations are very long. So the basic idea was just to have one trick which you have in your bag to share with the others. So the videos have to be, anything, whatever you want to say should not be more than 2 minutes, between 1 to 2 minutes. And the next is, be aware of gossipy boma, a post-vitrectomy scenario. So you must be knowing your order. Okay. So you are ready?
In our video, we showcase the art of ILM peeling.
Just a minute.
The first major step in
I'm not seeing the video. You are Dr. Shalini Kumari? Okay, her video is there. Meanwhile, I request Satyajit Sinha to come and share the stage with me. Is video ready? So start the video.
Device is being used for smooth conduction of phacoemulsification procedure. After doing routine steps with the help of 23 gauge forceps, the B-hexa device has been put inside the interior chamber. I am using the side port so as not to disturb the depth of the interior chamber. There are 6 phalanges, 3 phalanges, alternate ones have got holes, 3 doesn't have. My purpose is to put those phalanges with the holes beneath the iris. I am using the side port for this manipulation. The notches will engage the pupillary margin and will keep.
So 2 comments regarding this video. In the OPD, the maximum dilation of the pupil was only 4 mm. But intraoperatively, once we use the phenocaine and also the OBDs, the dilation was this much. But because it was a soft cataract and my previous experience with intraoperative meiosis, I decided to go ahead with B-hex insertion. Thirdly, we must inject some amount of OBD beneath the iris so as to create a space between anterior capsule and the iris so that we don't damage
that's okay, but what is the difference, or what is you feel is the different what others are doing, you are doing, others are not doing? What is the carry-home message?
Sir, in our setup, we don't have Malugendane and other things, so B-hex actually used.
So primarily, I think one carry-home message may be that you need to use the viscoelastic and use the side port. But I would have appreciated that the way you put it, and if you put it with the chopper,
manipulators
instrument, with the forceps and how to angle it, there should be some trick which makes the thing simpler, would have been better presentation. Thank you.
Welcome.
So we go to the next. Be aware of gossipy boma. What is that, gossipy boma? Gossipy boma looks like some gossip is going on. So alternate. And next will be Aditi Singh. Is she here? Yes. So be ready on that side.
So, no financial interest. On the first post-operative day, after PPV and SOI for RRD in a 45-year-old male, an unusually long cotton fiber was extracted from the posterior segment using microforceps. The whole vitreous cavity was inspected to exclude any retained pieces. Small amount of silicone oil was injected and the ports were removed. Gossipomas have been reported in only 4 cases after PPV earlier. Cotton fiber source may be earbud tip, surgical drape, or gauze pieces. Scrub nurses, surgeons, and assistant should ensure that no fibers are adherent to instruments introduced in the eye. Patient recovered a visual acuity of 6/18. This was a possible likely source of fiber. Thank you.
Thank you. Thank you. Very good presentation. Now we go on to the.
Actually, the Gossypium is the technical name or the botanical name for cotton. So that's why it's a Gossipiboma.
Okay, thank you. So, overcoming the lens iris diaphragm retropulsion syndrome. Aditi Singh. Yeah.
Be seeing ways to overcome LIDRS or lens iris diaphragm retropulsion syndrome, which is commonly seen in high myopic and post-vitrectomized eye. This is a high myopic case with axial length of 31 millimeters, where I had implanted +1 diopter intraocular lens. As you can see, as soon as I entered the AC, there was sudden deepening of the anterior chamber and widening of the pupil, so much so that hardly any iris is visible. As I proceeded with the surgery, it became more and more difficult for me because it seemed as if I was operating in a vertical plane. Ways to overcome or minimize LIDRS is to keep the infusion low, bottle height low, to keep the IOP low. If we are operating on active fluidics platform, we can even enter the AC with the irrigation off and gently press the foot pedal. The best way to overcome this is to use our second-hand instrument, the dialer, to gently lift up the iris. This breaks the reverse pupillary block and equalizes the pressure between the anterior and the posterior chamber. Thank you.
So, you are suggesting that we should inject the viscoelastic between the lens and iris diaphragm.
Sir, that was not one of my take-home messages. Rather, it was to use the best method to use the second instrument to gently lift up the iris. Either we can do it intraoperatively, but best is before we we increase the infusion or start the infusion, we can lift the iris with the second hand instrument so that there is no reverse pupillary block and the AC doesn't deepen. So one of the take home messages is that, sir.
Okay, thank you.
Thank
I
you,
think there was some paper published where they put on a viscoelastic between the
sir, that
iris
was
and the
over
lens.
for my clarity for the visualization, sir.
Okay, thank you.
Thank you, sir.
So, singeing and probing with Masterca stitch. Neha Arora. What? Next is 14 number. When in doubt, do gonioscopy. Anuja Janki Raman.
So,
So that was a nice video. The standard protocol is that you do a gonioscopy every time after traumatic cataract. So this was not
after
an initial.
any case of, if there is a recurrent iritis of unknown cause, because in this case we just thought it was a steroid responder and it's a rebound phenomenon after steroid withdrawal.
This was
But
post-operative.
It was so there was a IOL dislocation. Similarly, there are many times when we see epinuclear remnants also, which kind of can pop into the anterior chamber after many years of cataract surgery too. So whenever in doubt, I think that's when we do a gonioscopy when there is minimal inflammation of the anterior chamber or there is minimal amount of corneal edema also. then it is not a wrong idea to always label, to do gonioscopy instead of labeling them as toxic keratitis or as stromal keratitis.
Good presentation. Thank you.
Excellent, excellent, very good. Even I've seen some patients who had a chronic inflammation, the pupil was slightly, 9.
Quick.
Quick pull a best maneuver to rescue extending capsular access. 9 number.
Going into zonules, if you cross path zonules, you're in trouble. But the zonules are going to pull it out, you have to pull it in. Not
फिर
just
से लगा-
slow, but you
फिर
have to
से
go
restart कीजिए.
Can you
Restart.
restart and increase the volume?
excess OVD, just pull it quick. So here, capsular access is going into zonules. If you cross path zonules, you're in trouble. But the zonules are going to pull it out, you have to pull it in. Not just slow, but you have to go fast. If you pull tangentially, it is going to go out. Don't put excess OVD, just pull it quick. So here is the quick pull. If you go slow, it is going to go out. Just watch this. It's going slow, it's going out. Don't do slow. You have to go quick. You go quick, it comes in. You go quick, it comes in. Don't go slow, but pull it quickly. Just go. Watch this. Quick pull, very quick. And the CCC is complete. If there is radial tear going out, don't worry. You have to just pull it quick. There it goes. You put quick pull, it's in. If the tear is going out, you don't have to worry. Don't go slow, pull it quick.
Thank you.
That was very good.
Excellent, excellent, very good. But only thing at times, probably in the younger patient it is little difficult as compared to the older patients. Yes. But I think that jerk may do the trick because the granules are far more stretchable than capsule is. So in a younger patient, when you try to pull it, granules keeps on getting stressed and capsule gets torn much before the granules can give way. So probably that jerk may do the trick. So when you go do tangentially, probably you are not able to tear the granules at all. So that becomes a difficulty. I think very good presentation.
Thank you.
Excellent.
Thank you.
So now we come to the next. Prasanna Venkatesh Ramesh is here.
Checkmate. 10 number आ गया.
10 number आ गया. Shalaka Vagamare.
IOL following complicated cataract surgery elsewhere few weeks back. The initial steps of the surgery were uneventful, but during AC formation, there was Descemet's membrane detachment. In a state of panic, air bubble was injected to the same site where DMD had occurred. Post-op day 1 ASOCT showed a severe non-planar center and periphery involving DMD. So what did we do wrong? Failure to identify pre-existing small DMD at main port, continuous injection of fluid despite advancing edge of DMD, injecting air through the same port that caused the DMD. So now we planned for air desmetopexy through the temporal side followed by strict supine position. Post-desmetopexy ASOCT showed the DMD had resolved. So the take-home message here is rule out pre-existing DMD, recognize intraoperative DMD earlier, avoid using the same site of DMD for air desmetopexy, use ASOCT for diagnosis and management, don't panic. This is a case of left eye secondary SFIOL following complicated cataract surgery elsewhere few weeks back. The initial steps of the surgery were uneventful, but during AC formation, there was Descemet's membrane detachment. In a state of panic, air bubble was injected to the same site where DMD had occurred. Post-op day 1 ASOCT showed a severe non-planar center and periphery involving DMD. So what did we do wrong? Failure to identify pre-existing small DMD at main port, continuous injection of fluid despite advancing edge of DMD, injecting air through the same port.
Thank you. So I think a very good idea that whenever you have got a large DMD, I mean if there is a small you can go from the same port, there is no problem which is very visible. But if it is a very large DMD, if you go from the same port, it may be very difficult. So make a fresh incision and inject the air and they let the air come out from the main incision and unroll the DMD. Very good point. Thank you.
Thank you, sir.
So next is? जोर से बोलो यार.
Manik Sardana. He'll be speaking on bent ab internal needle goniotomy, inexpensive and effective MIGS for early moderate glaucoma.
Good evening, everyone. So 24 gauge needle is bent towards the bevel. Can you increase the volume? Goniotomy is prepared. The patient is tilted 35 degrees and the microscope is also tilted at 35 degrees. And the needle goniotomy is engaged into the trabecular meshwork and trabecular meshwork is excised. You can see the floating trabecular meshwork inside the anterior chamber. So around 90 to 100 degrees of goniectomy is done and this can be easily combined with phacoemulsification. Then after first we did the bent angle needle goniectomy, then routine phacoemulsification is carried out. And the ports for bang is used as one of the side ports in the phacoemulsification. So the take home message is, bang is an inexpensive and effective mix for patients of early to moderate glaucoma. Learning curve is short and no special instruments are required. Can be easily done by any ophthalmologist. Thank you.
So what type of lens is being used?
Sorry?
Which lens are you using for this?
So we are using Swan-Jacob lens for this.
And you do it before cataract surgery, after?
Yes, so we prefer it to do before cataract surgery. So if there is any hyphema or the remnant of the trabecular meshwork is left, that comes with the aspiration. So yeah, that helps.
Thank you.
Thank you, sir.
Now, skew deviation. Dr. Prasanna is here?
Yes, sir.
Yes.
Yeah, thank you for this opportunity. So this is an animated video for a complex condition like a skew deviation. So this video was made by myself. So you can see that the idea behind this video is neuro-ophthalmological structures are very complex. So we try to make a lot of two-dimensional or three-dimensional subtractive animative videos. In a single minute, can you deliver a complex scenario like a skew deviation, which is an acquired vertical misalignment of the eyes that is not due to any single nucleus or oculomotor muscle nerve damage. See, the first presentation, both eye there is an hypertropia. It is predominantly a concomitant one. Sometimes, rarely it can be an concomitant one. It doesn't have any particular nucleus or any particular pathway. It's a pre-nuclear vestibular input damage that occurs. So this is something that we wanted to make, and I have made a lot of animated videos for neuro-ophthalmology to sum up learning in a single minute, which we read for hours and hours in textbooks. Thank you.
I really could not understand what you wanted to show.
Yeah. Sir. Yes, sir. In a single word short, sir, I mean, more than a minute, there are many videos that we are making in a single minute to make ophthalmic learning very simplified. I took skew deviation because I read it for around 1 hour or so. I was not able to solve it around. So I wanted to make a film on a minute so that people will understand skew deviation if they watch it once, maybe twice or thrice. That's the idea, sir. Thank you, sir.
Okay, thank you.
Yeah, thank you. Thank you, sir.
No, it's not must to finish in 1 minute. I mean, it is 2 minutes time. And it's not absolutely, there is no competition over there. 5 or 10 seconds this way or that way will not make much of a difference. So the basic is that it should be with the speed that people can understand. I mean, it should not go so fast that we are not able to comprehend. Okay. That was the idea.
Okay, okay, sir. Thank you, sir.
So who is the next?
Skew deviation, spinning
John Sarkar
graph.
is here. Dr. John Sarkar.
Situation of basic surgery, how to settle the intract situation. Can you sound please? Sound please. Increase the sound. Sound. So the small graph, I am difficult to settling the thing. I am struggling to settle the dissect graph. I don't have a extra tissue, so I have to settle the surgery. I was struggling to settle the graft. I putting the air and dragging these things, suturing the main wound. I could not succeed the thing. Then I used this very small bubble. I was trying other side. I was not succeed. Then on table I decided to put a very small air bubble behind the graft and use it as a roller coaster and pull the entire whole thing centrally, and then the graft is central and complete the surgery and it will give a very wonderful outcome. 6x9 vision and follow, but the more one that you follow up. So you have the technical message is that if you have don't spare tissue, actually the graft size is always 2 millimeter less than the horizontal diameter of the cornea. But that time, inadvertently, my fellow the punch it with it's supposed to be graft 8.5 millimeter. She punched it a 7.5 millimeter, and I was in great trouble. So I don't have spare tissue. So what is the spinning intent? I was showing this dramatically, but that is difficult to settle the things. So on table I decided to use a very small air bubble behind this graft and use this air bubble as a roller coaster and pull it centrally and drag them. And as the central 7.5 millimeter oil compact by this dissect graft, so automatically post-op vision was really good, and plano with the 6x9 and the maintain the thing over the 3 years follow-up too also. That's the technical messages.
Good. Thank you. Now we go on to next minimally invasive IOL repositioning.
Thank you very much.
Dhyan Khatib.
Thank you. Good. Saurav is motivating everybody with the music.
So I'm going to be showing a minimally invasive technique to repair a subluxated IOL bag complex with making only 2 side ports. So where the area of subluxation is, we mark behind the limbus 2 points, and we inject a 26 gauge needle with a 6-0 proline suture, and we get it out through the first side port. This goes beneath the IOL haptic. Then we pass the suture back inside, and using the second entry point, we inject a 26 gauge needle between the haptic and optic, and with the second side port, inject this suture back into the needle, and we just gently pull until the IOL comes back into position. And without cutting the conjunctiva, we do a Yamane flange technique where we bury the haptics subconjunctivally. So with a minimally invasive 2 side port technique, we have managed to refixate this subluxated IOL.
What suture is this?
This is 6-0 proline suture.
Double arm straight needle is not available.
No, only the suture without needle.
So if double arm straight needle is available, then of course you can pass one below and one above. Much more easy. But of course you have to come back. Excellent technique. Well done.
Thank you.
Next is Dr. Vaibhav Sethi. When history solves the mystery.
A 29-year-old female came with both eyes decreased vision since the past 4 days. She had signs of periocular and anterior segment inflammation in both her eyes. Fundus hazily showed a few choroidal folds, but we were surprised to see a gross amount of subtenon fluid in both her eyes. So what was the cause of this bilateral posterior scleritis? On history, we found she had had left-sided carcinoma breast and recently received infusion of a bisphosphonate called zoledronic acid. On literature review, we found bisphosphonates can induce ocular orbital inflammation like posterior scleritis. We immediately stopped her zoledronic acid infusion and started her on oral steroids. She drastically improved in the next 2 days with improvement in the periocular and anterior segment inflammation. The fundus became better and the subtenon fluid grossly reduced. So this taught us a proper history taking and good literature search is very essential in solving rare clinical scenarios. Thank you very much.
Very good. Excellent.
Very good.
Now, next is...
So zoledronic acid is the most commonly used bisphosphonate by physicians and oncologists, and it is given every month by oncologists in cases of metastatic cancer disease and once a year by a physician. So it can cause vision-threatening episodes, and a simple history taking and sometimes save patients both eyes.
Thank you. Very good point. Now we have optic pit maculopathy and anti-VEGF. Jasneet Kaur.
So we had a case of a 31-year-old male who presented by incident. He went for a regular examination and he found the vision in one of his eyes was decreased. And to our surprise, on fundus examination, he had an optic disc pit as well as macular edema. And as you can see, there were retinal folds present. So temporal optic disc pit has most association with a maculopathy, which includes edematous inner retinal as well as outer retinal layers. There has been no definitive treatment established as of now for this condition. Various treatment modalities have been tried. So we tried anti-VEGF as one of the modalities. And in centers where higher equipment is not available, anti-VEGF can be one of the early emergency treatments that you can give before referring the patients further for PPV or any other such condition. Thank you.
Thank you. That was a nice presentation. We'll go on to the next presentation, Dr. Sushma Tejwan. Yes, please. She'll be speaking on trabecular bypass microstent, eye stent inject implanted at wrong position, how to manage.
My video is not here. Okay. So this is regarding a...
See how to manage if the eye stent inject gets implanted at a wrong position. These are very tiny implants that are placed in the Schlemm's canal. Note the first one is implanted in the correct position, but the second one has got into scleral spur. In case that happens, use the microforceps to remove it and then place it on a sponge, as it is very small and can be misplaced. Rethread it in the same injector and implant it in the right position. Note that the injector has total of 4 clicks for 2 stents implantation. So there are 2 extra clicks that can be used. In another case, it got under-implanted and was lying in the anterior chamber. Pick it up in the same way and re-implant it. Rethreading of the implant can also be done in the anterior chamber itself.
Thank you.
Thank you.
Nice.
Next, Ahan Shah is here. Don't blame the Wills bar for every time you hear a caustic
complaints of inability of the lid closure, deviation of angle of mouth towards the opposite side, and inability to raise her eyebrows. As associated complaints, along with the chief complaints of watering of eye and diminution of vision. Diminution of vision is gradual in onset, painless and progressive in nature. Watering has been there since the past 2 years. History of some surgery done 2 years back for some brain tumor. As you can see, here's the image where you can see there is a cyst, the swelling is cystic in nature, and it's there on the rectoauricular space, and there is an incision scar over it. Here is the NCCT finding. As you can see, there is a diffuse hypodensity, well circumscribed in the posterior fossa on the right, near the right mastoid region. So this is the Sutland photo where, as you can see, there is a leukomatous opacity in the center with surrounding nebular macular opacity with conjunctival ingrowth from the nasal side
keratopathy, as can be seen,
with superficial vascularization. On fluorescent stain, you can see that there is confluent SPKs. There are confluent SPKs above and below the flesh ingrowth and also on the conjunctiva.
So this patient had acoustic neuroma excision, following which he developed delayed facial nerve palsy, whose incidence is 16 to 25%. If this patient had followed up after the surgery in the next 3-4 months, or if she had known that, then this patient's vision in right eye would not have deteriorated to a whopping 360. So early detection, referral and management of such cases following this kind of tumor surgery can help save the vision in the eye. That is the take-home message I'd like to say.
Thank you.
Thank you, sir.
So now we come to the next, Bruns nystagmus. Najwa Shereen. Yeah.
Good evening all. My topic is Bruns nystagmus, a vital clue in diagnosing cerebellopontine angle tumor. We present a 41-year-old female with gradual onset, right-sided hearing loss, defective vision, and headache. On examination, she was found to have a coarse, large amplitude, low frequency nystagmus on rightward gaze, and a fine, small amplitude, high frequency nystagmus on leftward gaze, which is consistent with Brent's nystagmus. Brent's nystagmus is a bidirectional jerk nystagmus with alternating slow and fast component. The basic pathophysiology involves simultaneous impairment of both flocculus and vestibular neural network. On fundus examination, she had bilateral established papilledema. Fundus finding and Brent's nystagmus helped us to clinically predict a right-sided cerebellopondylangular tumor, and it was confirmed by MRI. Brent's nystagmus is an important clinical sign both in the diagnosis and localization of cerebellopondylangular tumors. Thank you.
Thank you. Now we come to the next cortical cleaving hydrodissection. Jayashri Barua. Dots that do not connect. ये कुछ आया नहीं है. Devi Priya. Yeah.
Yes. Play the video.
Do they connect or not? Come, let's find out. 35-year-old lady came with the complaints of blurred vision and photophobia, but everything was normal. The next day, she came with an increase in symptoms. This time, fundus showed hyperemic disc with multiple yellowish-white clock-like lesions in the posterior pole. OCT showed no macular edema. FFA showed that the lesions were hypo in the early mid-phase, which became hyperfluorescent in the late phase. Diagnosis of APM-PPE was made. So, the dots do connect with each other, even if they do not. After a course of oral steroids, she recovered completely. 1 minute takeaway point is, if the patient has symptoms, even when the BCVA is 6.6, there is something really wrong. Look beyond, dig deeper, and do it all over again. Thank you, AOS, for the wonderful opportunity.
Very good point.
Thank you, sir.
Now we call beyond the usual suspect an atypical cause of a scleral nodule. Sara Rijvi.
Talk beyond the usual suspects. 38-year-old male presented with bilateral sclerokeratouveitis. Left eye had giant multiple epibulbar nodules with keratouveitis, so did the right eye. Investigations led us nowhere. Montoux was positive, so we started ATT with steroids and saw no improvement. Repeated the biopsy and found these histiocytes with classical emperipolysis with S100 positive on immunohistochemistry. So non-resolving epibulbar nodules with S100 positive, what is the cause? We arrived at extranodal Roside-Hoffman disease. Started oral methotrexate, continued the steroids. In 1 month saw significant improvement. So Roside-Hoffman disease, it's a rare but potential DD of scleral nodule. Thank you.
Very good. Excellent. Now we go on to the next hardest test of patience. Sudipta Mitra. This side.
Thank you, AIOS. Aishwarya Kadam, I think it's not. Should I go down? That is mine, the last one, if you want. Last wala, wo last wala. This was sometimes hurrying up or being too relaxed puts us in trouble. So this was a very last case of the day, a nice femto, but suddenly the patient jerked and the IOL went and hit the iris, and immediately as the patient, we tried to dial in the IOL, the patient party was looking, and this is what happened because this was being transferred live from the theater, and all my adrenaline rose up. Immediately, I wanted to take out all the blood so that I did not see behind the eye well. Put in viscoelastics, tried with adrenaline, nothing was helping. Again, the blood was coming again and again. As I said, hurrying up was making me forget that you need some time to allow the clot to form. So finally it clicked. We put some visco over, kept a closed chamber for 1 minute, and after that 1 minute, it was all well. So sometimes in a hurry, we just forget the very simple things that could save our day. Thank you so much.
Thank you. Double trouble, no, I think bleb needling, punching to inflate. Is Anup Singh here? So next is double trouble and encounter with bilateral endophthalmitis. Angle structure.
A cappella. A 33-year-old female presented to a cataract screening camp in rural part of the angle structures. A cappella. A 33-year-old female presented to a cataract screening camp in rural part of Tamil Nadu with complaints of gradually progressive painless diminution of vision since childhood. Her uncorrected visual acuity was 6/16 both eyes with pinhole improvement up to 6/18. Following findings were noted on torchlight examination at campsite. A V-shaped indentation in lower lids was seen in down gaze. On inspection from temporal aspect, cornea appeared protruding and steep throughout. With the help of torchlight, anterior chamber angle structures were evident unaided from anterior to posterior being Schwalbe's line, trabecular meshwork, scleral spur, ciliary body band, and also root of iris. Provisional diagnosis of keratoglobus was made. The interface between the tear film and the ectatic cornea changed the critical angle, thus preventing the total internal reflection and making it possible for the examiner to visualize angle structures without gonioscope. A cappella is a form of singing which doesn't involve any musical instrument. In this case as well, visualization of angle structure without gonioscopy is like a cappella in our ophthalmology. All the images were shot on smartphone.
Thank you.
Can we have the next speaker? Bleb needling, puncturing to inflate. Dr. Anup Singh.
Commonly done procedure to revive a failed flat bleb post-trabeculectomy, where mitomycin is injected in subtenon space and is distributed across the area using soft bud. A 26 gauge needle mounted on 1 ml syringe is used to enter the space and is moved around to break the form fibrosis. Same needle is then used to lift up the flap and swiped underneath in order to open the tract. Sometimes this procedure may form the bleb, but still if it is not forming, then it can be used to enter the anterior chamber and reopen the closed ostium. Sudden elevated bleb is a sign of successful needling.
Thank you.
So what percentage, how much quantity, any control or just?
So ideally we can take 0.1 to 0.4%, but depend upon the time of exposure, we have to decide that, and also the amount of fibrosis which we encounter.
And no need to wash, just leave it over there?
So we are using very small volume. When we go inside for bleeding, we will have a little amount of saline also to just back flush and aspirate a little bit of mitomycin during the time of
during trabeculectomy, we actually advise wash it profusely with 20 ml of, but over here we are leaving a lot of quantity inside. Any problem encountered in any of the cases?
No, sir, not so far. But
how many cases have been done?
Sir?
How many cases have you done?
So around 7 to 10.
Okay, thank you. Very good point.
Thank you so much, sir.
Can we have the next speaker? Double trouble and encounter with bilateral endophthalmitis. Dr. Kshitij Raizada.
Very good evening, everybody. So we had a 76-year-old female, diabetic, immunocompromised, and she had history of hospitalization for 2 weeks for acute pyelonephritis and history of diminution of vision for 2 weeks in both the eyes. PR inaccurate in both the eyes, and she had bilateral endophthalmitis. Bilateral endogenous endophthalmitis, and we advised her simultaneous bilateral pars plana vitrectomy under extremely guarded prognosis. So we first removed the fibrinous membrane over the IOL. And we proceeded with vitrectomy, and after having done the core vitrectomy, what we found underneath was a pale ischemic and necrosed retina in either eyes. So there was no visual improvement after this surgery, but the only benefit we could give to the patient was immediate resolution of pain in both the eyes. So the take-home message is that delayed intervention in endophthalmitis yields poor results, and immunocompromised patients are susceptible for endogenous endophthalmitis, especially bilateral in this case. Thank you.
No, both eyes had no improvement.
Sorry, sir?
He had endophthalmitis in both eyes?
Yeah, she had bilateral endogenous endophthalmitis.
And no improvement in any one of the eyes?
No vision, because it had been almost 14 days since the onset of the disease. So we took her, she was under immense pain, and the overall general health of the patient was poor. So we took her for simultaneous bilateral vitrectomy. But we could only give her relief in pain, but no visual improvement.
Okay. Thank you.
Management of sclerotic nucleus with weak zonules. Presenting authors, Dr. Saurabh Kamaldatta.
Here we see a patient of nucleus that is a sclerotic and with weak zonules. So the nucleus is moving here and there inside the bag. So if we manipulate too much, there can be subluxation, dislocation, or even lens drop if there is rent. So what is the solution? Solution is to fill up the bag using viscoelastic. So we filled up the bag, but how to bring it out? We have to bring it out using a lens dialer and depositor. We use depositor to support and the dialer to bring the nucleus into the antechamber. Then by using irrigating vectors, we can simply take it out from the tunnel. So the take-home message is that we have to take one step at a time. Small nucleus has to be brought into the AC first using dialer and depositor after filling up the bag with OVD to avoid complications. Thank you.
So what was the problem in doing phacoemulsification in this patient?
We don't have phacoemulsification in our institute.
So in any case, I mean, if you don't have a phaco and it is primarily for SICS.
Thank you.
Next is when in dilemma, look at the macula. Presenter, Dr. Isha Gupta.
Dr. Anu, इसके बाद हम बोल
रहे हैं. My 1.2 planned surgery in 200 retraction syndrome with upshoots. A 17-year-old girl with severe abnormal face turn presented. In dilemma, look at the macula. My 1.2 planned surgery in 200 retraction syndrome with upshoots. A 17-year-old girl with severe abnormal face turn presented.
वीडियो चल नहीं रहा.
Look at the macula. My 1.2 planned surgery in 200 retraction syndrome with upshoots. A 17-year-old girl with severe abnormal face turn presented. 30 prism diopters of exotropia and 15 prism diopters of hypertropia of left eye with grade 4 upshoots in the right gaze. For abnormal head posture, we planned a bilateral MRI session, but the hypertropia with
The video is not playing in sync with the audio.
with left eye type 3 DRS with 30 prism diopters of exotropia and 15 prism diopters
So you can.
We'll take the next speaker. You can check out until then. Yes.
You can switch off the audio and speak yourself. Yeah. Now let's Dr. Satyajit Sinha present his point and you can go and check.
Caution in planning management of traumatic cataract. Dr. Satyajit Sinha.
I just wanted to show a small, simple video over here. This is a case of a traumatic cataract, and you can really not see what is behind the iris where there is synechia. So you have to be very careful, and when these patients come to your OPD, one of the most important things that you should and must get done is an X-ray, simple X-ray, and not a MRI sort of a thing, because you don't know whether the particle inside, if there is any particle, whether it's wooden or metallic. You have to be very careful when you are removing the synechia also, because you don't want to cause any iridodialysis, because this has been there for a while now. And you have to be, all the debris which is there on the iris margin is removed. And you really don't know whether this foreign body has actually pierced the posterior capsule also or not. So you have to be very careful. And something which was not visible then, now this metallic part has come out, small airgun pellet was there, and it has come out of the lens. So this is the thing which I wanted to show you for a 1-minute take-home message, that you never know what is underlying the iris, and you must order a simple X-ray when you do see these cases in your OPD. And then that part is a routine cataract, and wherever the tear is there, you cover the rhexis within that, and then you complete your. And it may also be a good idea to do OCT to see the status of the posterior capsule in such cases. Thank you.
Thank you, Dr. Satyajit Sinha.
Next is the art of ILM peeling. Presenter Dr. Atul S. Puttalanth.
The flap. Pinch and peel technique is considered the most common and widely used method for gently lifting the ILM flap over any vascular problem. There are other methods like using Tano's diamond-dusted membrane. In our video, we showcase the art of ILM peeling. The first major step in ILM peeling is raising the flap. Pinch and peel technique is considered the most common and widely used method for gently lifting the ILM flap over any vascular prominence near the arcade. There are other methods like using Tano's diamond-dusted membrane scraper to lift the flap initially. Using finesse lobe is also an option.
(1.2) planned surgery in 200.
Surgical situations with ILM peeling. The first case is the management of a full thickness macular hole using inverted ILM flap technique. A 2.5 area of ILM peeling was performed compared to the diameter of the hole. The hole was then covered with inverted ILM flap. In this case, a thick anomalous vitreous sheet was noted as it was scantily stained with heavy BBG dye. After removing this layer and restaining with heavy BBG, finally the ILM was stained well, and rest of the ILM could be peeled in a regular fashion. This case was an optic disc maculopathy, and ILM peeling was initiated to remove the vitreomacular attractions. The ILM was gently removed, and the same was used to close the defect in the optic disc pit. ILM peeling can also be done under the cover of PFCL. Thank you.
Thank you. Where the video is come? I think the last one.
Dilemma, look at the macula. My 1.2 planned surgery in 200 traction syndrome with upshoots. A 17-year-old girl with severe abnormal face turn presented with left eye type 3 DRS with 30 prism diopters of exotropia and 15 prism diopters of hypertropia of left eye with grade 4 upshoots in the right gaze. For abnormal head posture, we planned a bilateral MR recession, but the hyperopia with upshoot posed a dilemma. Do we plan a superior rectus recession or inferior oblique recession? A glance at the posterior pole cleared our choice. We did not find any macular torsion, indicating that there was no inferior oblique overaction. We went ahead with the plan to recess superior rectus, which worked very well in this case. There is evidence in literature supporting both the approaches to correct upshoot and DRS. So when in dilemma, look at the macula and also at your mentor first and foremost. Thank you.
Thank you. Anybody left now? All done? Okay, thank you all of you for being here. बड़ी जल्दी ध्यान आ गया इसका.
They had called your name.
Anyway, just put it on. What's your name?
If you had just sent it, then it's not uploaded here.
No, take it. It's okay. You given the pen drive? Please do it.
अभी है तो WhatsApp कर दीजिए.
नहीं, इसको लगा दो ना पेन ड्राइव से. नहीं चल सकता क्या पेन ड्राइव में? हैं? क्या कह रहे? यहाँ पे कम है. नहीं उसको नहीं एवी वाले आदमी बुलाओ, सीधे लगा दो ना पेन ड्राइव में. क्या परेशानी है? क्या कह रहे?
मेल कर रहा है.
ऐसे ही चला दो ना, ऐसे बिना मेल के वैसे ही चला दो ना.
चला दीजिए सीधे.
या यहाँ पे इससे चला दो सीधे पेन ड्राइव लगा के लैपटॉप में. पेन ड्राइव लैपटॉप पे कनेक्ट नहीं होगा क्या?
ईमेल कर दो, अभी टाइम है.
It's okay, sir. कहाँ इसका नाम ऐसे नाम ऐसे लिखा ना, ऐसे बड़े बड़े लिखने चाहिए सर. बरुआ कॉशन इन प्लानिंग क्या नहीं कॉर्टिकल क्लीनिंग हाइड्रो रिसर्च. इसको तो हमने बुलाया भी था. चलो तुम देखो, मैं चलता हूँ. मेरे को थोड़ी
इसके फादर भी बहुत फेमस ऑप्थेल्मोलॉजिस्ट हैं गुवाहाटी में. अच्छा, बड़ा सेटअप.
तभी तुम जाते हो.
Dr. Jayashree will be speaking on cortical cleaving hydrodissection, the savior. नहीं जा रहा है. एयर ड्रॉप कर दो, स्क्रीन शेयर कर दो, कुछ तो कर दो यार. किसी तरह से उनका फोन ही कनेक्ट कर दीजिए. सौरभ भाई टेक सेवी कुछ करो भाई. क्विज में जाना माइक्रोविजन. हाँ Abhi, we have 15 minutes for this session. Maybe God saved it for you. This session ends at 5:15. It's 5 o'clock now. आप कहाँ पे हैं डॉक्टर अनु? हाँ हाँ हाँ. अभी आई नहीं. नाम अब आप असिस्टेंट प्रोफेसर हैं क्या? आपको अब हम लोग पटना बुलाएंगे कॉन्फ्रेंस में. म्यूजिक में कब से आ गए? और कोई गाना बनाया हो कि यही है? बहुत बढ़िया. गया बोलना है तो बोलना है चाहे जो हो जाए. हाँ हाँ हो गया ना. भाई अपलोड हो गया. इधर सीढ़ी इधर. रुकिए रुकिए रुकिए. स्टॉप स्टॉप. फिर से चला दीजिए.
So sorry to keep everyone waiting. Just a simple tip on easing your phacoemulsification, the importance of cortical cleaving hydrodissection. The beauty of cortical cleaving hydrodissection is that once you get the fluid way passing through and through from one end to the other, it makes your irrigation and aspiration very easy, and sometimes you don't even need to do it. So at the end of the case, it looks, yes, everything is fine. I just have a little bit of cortex. I asked my assistant to open the IOL. Then what I noticed is this. See, we had an etheric posterior capsule and we had the entire epinuclear sheath out there. And this again took a long time. So here lies the importance of a good cortical cleaving hydrodissection, because if you have noticed in this video that initially there was an inadvertent hydrodelineation that I didn't want to happen, but because of the hydrodelineation, a very clean epinuclear sheath was left behind. So my single take-home message is that a good cortical cleaving hydrodissection, not in all the cases, but in cases where it's required. Thank you.
Thank you. That was a nice presentation. Very good. We got to see it. Thank you. Thank you very much. That brings us to the end of this session, and we'd like to thank everybody who were patiently waiting here for the session to be completed. Thank you so much. Dr. Annu, 1 minute rukega. Dr. Annu, can we call all the speakers on the stage, please, for a group picture? आप लोग इधर है, लड़की लोग उधर, लड़का लोग इधर.